Welcome, everyone.
Thank you for joining us today. Our second Parkinson's Journey program here in partnership with the Inova Parkinson's and Movement Disorder Center. I'm joined here with Josefa Domingos, a physiotherapist specializing in Parkinson's for the past 20 years or so. I'm John Dean. I'm a speech language pathologist. I also work exclusively with people living with Parkinson's and related disorders. And we're going to talk today about pain in the back.
So, yes, we are going to be talking about a topic that, let's say, when I finished my physiotherapy school, my thesis was on back pain. And at that time, I remember reading stuff about how everyone will eventually have one event of back pain in their life, right? So I think it's a too common topic, but obviously we want to really make it more specific and dive into how it affects Parkinson specifically. It is something that I deal with it daily, and I would say besides gait, that is probably the number one thing that physiotherapists address in Parkinson. So my main goal is not to cause you any pain throughout this topic, to be as practical as I can. So hopefully we can give key messages, but without overloading anyone. Obviously, we have to put this into context, and we have to recognize something that actually in the last 5 years maybe is gaining more visibility. Pain is something that was described right from the get-go in terms of Parkinson's disease by James Parkinson, but it hasn't been addressed so with more studies and research as it has now in the past maybe 5-10 years, when we recognize that non-motor issues were really having a greater impact on people's lives. Now, we've summarized here that we believe that to manage back pain, we have to really dive deeper into 3 different key issues. The cause means we try to understand what is the underlying reason why the person is having the back pain. And once we figure that one out, then we are more confident about which direction to go. Sometimes that might be quite difficult because it is a multifactorial problem. You can have different types of things contributing. And so it's also very helpful for us to understand what are the activities, the emotions, the whatever factors that might contribute, even the weather, for example, that's what I was thinking, that make it worse. And then what guides us on sometimes if we are really lost and we can't really seem to think about, or the evidence, I would say, is little on solutions. And one of the things that guides us most on having better and practical solutions is thinking about what makes it better. What makes it better is usually the guide to the solution. So let us use this structure today so that we can try to come to some conclusions about how we can approach this. And if we think about how do we get to the cause? How do we understand what's going on? I want to give you here a scenario. So this is, imagine you are in the doctor's office and you are complaining, okay, I have back pain bothering me. This is the underlying problem. And then suddenly you will, in an ideal world, what should happen, no matter what profession you are with, a bomb of questions should be lodged. And you'll have things like, okay, so tell me, where is the pain? Can you show it to me? Does it stay in one place? Does it irradiate to any other place? Is it only one pain? Is it 2? Can you describe what type of pain? Is it a burning? Is it a sensation? Is it aching? Is it a shooting? When did it start? Was it something that you woke up in the morning and you had this pain? Was it something that gradually was sinking in? How long does the pain last? So is it something that is constantly there, always the same, doesn't change in any position? How does it behave throughout the day? So let's make a plan here about when you wake up in the morning and until you go at night, and also through the night, how does this pain impact your capacity to do activities? Does it disrupt your sleep? Does movement make it worse? Does it make it better? Is it present even when you don't move? Does any activities or is there any type of stressful situation that will make it worse? And as I mentioned before, how about the influence of temperature? People always mention there's an impact on pain as well. And then we continue in this. So we'll imagine that the person then would ask you what type of treatments have worked before and what have not worked is also very important for us to know because people tend to try lots of things. And then the conversation goes on. Does the pain improve in some way with your medication from Parkinson? This is a key question. What is the impact then? We have to address to see how much is this actually bothering you or stopping you from doing the things that you are doing so we can think about how we should intervene quickly or not. How about all this can bring on a lot of anxiety, frustration, and depression. And if that gets worse, we know that everything else also gets worse. So as you can see, each one of these questions would bring on a response that will probably even bring on more questions. So it's not as simple as just, okay, tell me you have back pain and I'll tell you why you have it. And this is an important message here, which is how many of you believe that all these questions are possible to do in half an hour that you have with your neurologist? Can I have a show of hands?
Yeah, nobody.
Yeah.
It's the complexity of Parkinson is there's so much that has to be covered in a consultation. If we're talking about the neurologist here, that it's even worth thinking if the pain is tremendously your number one problem, does it make sense for me to say only at the end of the consultation, oh, by the way, I have, you have 5 minutes left and you tell the doctor I have back pain. Versus maybe I should really think about setting a time and maybe even have a consultation just to discuss this. As you can see, it can take a long time. I usually take about 1 hour and a half to get to the real depth of what is going on. And we still have to give people homework so we can understand it. But, okay, moving forward on the limitations that we have at this moment in terms of how to identify, what will happen if this doctor that's here, if the doctor knows Parkinson, what should be going through her head at this moment is this pain related to Parkinson or not? So it's natural that if you are contacting someone that's not aware of the impact of pain in Parkinson, he will probably go to his comfort zone. So which means maybe if it's a physiotherapist that's not aware of this influence, he was, it's something in your bones. If it's an acupuncture, they'll say it's something in your muscles. If you go to a massage therapist, they'll say your muscles are tense. This happens often. I do have a lot of patients where they tell me that. And I say, have you mentioned to your massage therapist that you have Parkinson? Because, the rigidity is kind of like implicit in the diagnosis. So I just want to share with you, it's like depending on the professional that you go to, they will tend to go to what they know best. And so it is important for us to, where do I go? Which one would be the most important? If I had to recommend anything, it would be certainly address this with your movement disorder specialist before going to other. But we do hope at the end we can give you more competence so you can decide that. So imagine, this doctor is deciding if it's Parkinson or not. But we do aim with these talks to give you also the skills to more or less be able to identify if it is or not related to your Parkinson. Okay? I think we are at a time where we can have the luck of technology to help educate more people and to be able to share what the doctors are also learning. So there are some elements that guide us and guide the doctors. These are criteria that are used for the doctors to know if it is or not related to Parkinson. One of them is, okay, when you were diagnosed with Parkinson, imagine that you already have a long history of low back pain, which could happen. It's very common. But when you got diagnosed, did it become worse? Right? So just the relationship, trying to understand when my diagnosis, and we know that the symptoms of Parkinson come or are present 2, 3, 5 years before, even more, depending on the symptom that we're discussing. So this might not be on its own as strong. But the next one is like, does the pain improve when you take your Parkinson medications? And I will alert you for the moment where we take the medication. is usually the transition time when your dopamine levels are lower, right? So those maybe 10, 15 minutes before and the 10, 15 minutes after are usually when the dopamine levels are actually changing, right? So they will be increasing as you take it. So sometimes people say, no, I take my medication, I don't feel anything. It's like after 10 or 15 minutes, do you feel that your pain becomes better? Right? So just alerting for that. And specifically if it's pain that's most related to the most affected site. So as you know well, this Parkinson disease is asymmetrical. There's one side that usually is more affected than others. That has to be because it's part of a diagnosis. Sometimes you might not notice it so much because it might be your right side and you've always used your right side. But there, in order for us to have a certified Parkinson diagnosis, it should be. And the pain that's related to Parkinson is more usually on that side. Then we have maybe not so much the person clear on the term medication, but feeling that throughout the day, the pain seems to fluctuate. So sometimes we have it more or we have it less according to the time of the medication that you're taking. So when we talk about motor fluctuations, it can be motor or non-motor. As I say, this is a more recent area, and which means it's the moment of transition of the medication. And this can manifest itself in different ways. So imagine that a tremor is one of the symptoms that you're dealing with. And as we have these fluctuations, that's when the tremor gets a little worse, right? Or if it's more rigidity, then that's when the rigidity becomes worse and you might feel more slower. If it's non-motor, maybe it's the moment where you become more anxious. So this manifests itself in different ways for people. And just to know that probably the pain will be increased according to those symptoms that appear. I'm going to add in one. So these are the top 3 that are used to guide clinicians. And I'll add in this one as a physiotherapist, which is I will always see that pain related or that is most contributing to the pain, if it's Parkinson, will improve with movement. Now, I want to give you an example. It just happened the other day. So it's this gentleman that comes in and he's like limping in to the clinic. And I said, is something wrong with your foot? He says, it's just, I usually have this pain in my foot. But the way the gentleman was walking, I was like, it looked like he had strained his foot, right? And she says, oh no, this just happens to me often. So these are keywords like this happens to me often. The gentleman doesn't seem to be bothered by this pain, but it's obviously impacting his walking. And the first thing I'm thinking is like maybe he hit it somewhere. Maybe he got injured. Maybe it's inflammatory. By instinct, what I should do is put some ice on it and get him off the foot. But for some reason, I said, you know what? If he came to the clinic, usually if you're really in pain, you don't go to the clinic. You don't. He wasn't going there for that pain, right? And so I said, I'm going to take the risk and let's walk on the treadmill a bit. The difference, and he starts walking on the treadmill, and suddenly what I asked him about maybe 10 minutes in, so how's your pain? And he says, oh, it's gone. And this, as I said, it was a risk because it could be an inflammatory situation. But the truth is, all the indications that were telling me is like, this is someone that deals with this pain often and he doesn't really value it, right? Walking on the treadmill is completely different than walking without being on the treadmill, I was walking with him with his hands on the rails, right? So that means I was supporting his balance. He didn't have to compensate so much, which means if he was walking while he was walking to the clinic, it's different. He was probably compensating a lot. So without complicating, I just want you to tell you that sometimes it's not so obvious because these Parkinson pains have, this was actually a published paper that just came out.
Yeah, I'd wonder too. I mean, you have these other comorbidities like an arthritis or something like that that's in there. If this just came out, this is a really great group of a well-known group in Germany. And what they did is they had people just for a couple days do 3 different diaries. So they had a diary where they were talking about whether the medications were on or they were off. So they're providing benefit or not, or they had dyskinesias. And then they also had one that was the King's Pain Scale, which is the reference right now. They have King's College. and then also symptoms, so like a symptom diary. And I think what they did is they just followed it for a couple of days, every hour logging this, and it gave them really high resolution data. What they found were a couple of things that we would expect. People in the morning, about 35% of the time, that's when they were having the most pain, and that's probably because the medications were at the lowest level overnight. And then people in the off state would also have issues as well. But then they also noticed that people who were really on, in particular, they were discontent, they also had pain issues as well. And it just ties into what we kind of already have figured out here, that there are elements of pain that directly tie into the non-motor symptoms, the non-movement related symptoms, and then the influence of the medications over the top of that can really influence it. It can really make it more severe or lead to a direct pain issue.
Mhm. So you mentioned someone actually had back surgery, but then they might have some dyskinesia, which is involuntary movements that sometimes is associated to the medication, but not necessarily. And so that means you have more abrupt movements that the person's trying to control movements so that he doesn't have back pain, and then suddenly he's dealing with dyskinesia. That could be an example of how it's influencing it. And the off state, obviously, what means is what I said earlier, is the rigidity increases, and so that can have an influence on the whole process of pain. And I will highlight as well that the perception of pain is also altered in Parkinson. So it's even more complex, which means maybe what I feel like as a pain might be felt. What I feel that is not painful might be interpreted by someone with Parkinson as painful, right? So the perception, how I feel pain, is changed. Okay, so sharing with you also some of the results from the questionnaire.
Yeah, well, we had a group of people that said absolutely positively yes. Okay, so 32%, about a third, and another third said partially or possibly, and that gives you, so 2/3 of the people are dealing with some kind of pain, back pain, that is related to their Parkinson's symptoms, and then fully another 20%, 19% actually said they're not sure. And maybe if we were able to, by the end of this lecture, provide you with the whole range of the ways it can influence, maybe there'll be people who are either partially or yes. And then the absolutely no, well, it's only 15%. Yeah, so it's a very small group. And it speaks to this because, again, 20 years ago, they weren't talking about this at all.
Yeah, I was suspecting that there might be difficulty to understand it based on my experience, that it's related or not. So I think this is an important message, is some people might not know that it's related to. So hopefully we can change that. And then obviously it's like the key question that I told you that a health professional has to ask you, or you have to ask yourself, does it change with the medication? And as you can see, we can have different feelings. Does it get worse? Does it get better? Does it stay the same? Or you might not even be sure. Now, let's think about questions that came from the question. Someone in line with what we were just saying that he's going to meet with his doctor next week. And so by increasing the medication, could this provide back a relief of pain in the back? So hopefully with this, what we just referred, we can reinforce that it can have, that's true. Now, imagine every time you have back pain, you're going to increase your medication, could be an issue, right? Because people are very resistant or fearful of increasing medication. So it's okay, now every time I have back pain, I'm going to increase my medication. I think it's just, it is a problem that deserves a greater discussion because it has a great impact on your quality of life. And in a time where we feel that people are trying to even reduce their medication, they start exercising, they want to reduce the medication, just knowing that if you are under-medicated, you might have more pain, is an important message. So we hope you understand that there's a relationship. And at this time, I will not be surprised that the doctor would know that there's a relationship. What she needs to know from you is probably, or this relationship, yes, I feel that when I take my medication, that it does improve, or in what specific moments. Okay, so now we do have situations where, okay, let's just think about examples, what would be unrelated to Parkinson. Here would be the type of pain that I would say would be more inflammatory, so more constant, more acute, more severe. And usually people have that instinct that something here is not right. So they usually what I call playing ping pong, which is going through one doctor and then another doctor. Uh, what unfortunately happens often is they might go to the neurologist and the neurologist says this has nothing to do with Parkinson. Then they go to the orthopedic doctor and the orthopedic doctor says this has nothing to do with me. And so people sometimes find themselves quite lost in this. And when I'm just putting two doctors here, can you imagine the amount of professionals that people usually go to? So these were most the ones that the group referred that they go more often. But I have experiences where people run through all types of professionals, acupuncture, all types of electrostimulation. They try everything.
Osteopaths. Yeah.
And when they ask me, it's like, if it will take away your pain, I know how hard it is. I can imagine how hard it is to live with pain. So I respect the attempt of trying to solve it always. Even though we might not have evidence for it, that means we just don't have enough tools to be able to help. But always keep in mind, if it's related to Parkinson, then that means the solution is in the Parkinson world, right? I want to highlight two that are very common, which was one of the questions that also came in, which was arthritis. And there is actually a connection of Parkinson and arthritis. People do have both. And so this person was like, when do I know if one is one? So arthritis is basically something that your rheumatologist can really help you identify. So it's something that's easy to identify if you have it or not. And then obviously as you're living with the situation, you might have moments where the pain gets worse or not, and you might want to try to understand, is this more the arthritis or is this more the Parkinson? Where should I go? I would imagine that you're probably being followed by both of these professionals, and so both are valid in terms of finding the answer or helping you in a certain crisis situation. But here's just a little guide, which is, again, that suggestion if it gets worse with movement, right, and improves with rest, which is typical if you have something that's inflammatory. So arthritis is likely the culprit there.
And you're speaking particularly to a rheumatoid arthritis, not an osteoarthritis, where with an osteo, yes. That's why the blood work could be so clear in a rheumatoid arthritis and see it right away, and that's why you should be able to address it.
Mm. So then again, it could be a few. So if we see, okay, but maybe it's accompanied when I do have that pain, it's something that fluctuates. It's always with me, because sometimes you might have crisis in arthritis, right? So it's moments where you have it. But Parkinson pain will come back. It will go, it will come back. And obviously the key message is it improves with movement, right? So hopefully that is useful. Let's grab on to another example. Now this one is the one I deal most with, which means when we have nerve that is affected. So back pain is usually related to sciatica pain, right? So that's a neuropathic pain. That means that the nerves are being compressed somehow. Now, can you think about all the multiple ways that this compression can help? How this compression can happen. So yes, we can have a fall and maybe something gets compressed. Or we can just have simple changes in posture, which we know might associate to Parkinson. And that on its own, on the moments that the rigidity sometimes is really strong and could be already contributing to the problem. So it's not easy to say this is only Parkinson or this is only, something that is happening in the back and changes. I find it quite difficult to separate both what happens, but you do go to one doctor and say, no, you clearly have to have surgery. And then you go to the neurologist, no, you shouldn't have surgery. And again, the person is in ping pong mode, trying to make sense of, should I have it or not? Usually, people will indicate surgery in Parkinson, if they are reasonable, as a last resource, because they know that the evidence does not support so much the surgery, right? They will try everything else before they go into surgery. So this is normal practice, I think, or safest practice.
Yeah, first do no harm.
Unfortunately, it doesn't always happen like that. So let's keep this in mind, because it's if this type of pain is happening, we must try to see and focus on, okay, so does what I'm doing contribute to this pain or not? In order to help guide you in these conversations with the health professionals, we find it's useful for you to have a diary. And so we put those questions that you saw in the beginning. Imagine you go to the consultation and you already take something like this. Do you see how much time you will save on the doctor asking you all those questions? So this is one way for you to get a little control and a sense of knowledge. Because sometimes I'm asking, so what makes it worse? I don't know. What time of the day is it worse? I don't know. If we keep answering, I don't know, the health professional is not going to guess what you're paying, right? It's because it's all based, pain is, it's a personal, subjective experience, and we have to try to understand how it is affecting you. So hopefully, we hope that at least this slide.
And this will be available too. I see someone trying to write it down here. The slides are always going to be available on the IPMDC.org website. So the video will be available, obviously, and then you can capture this, and then you don't have to. One thing, and I didn't mean to cut you off to midstream on there. I think it's very valuable to capture this information, but perhaps only a couple of days before.
Oh, yes, that's a good point, right? Usually it's like a week before the person goes to the consultation if you're dealing with that issue ongoing. Or imagine you had a pain that suddenly happened, which I'll alert you for this. So something that I didn't have pain and then suddenly I have an acute pain. That should be a different type of action for you, because pain might be coming in, but it's not supposed to, in terms of Parkinson, right? It's not supposed to happen suddenly. That is a crisis that, imagine, I'll give you a practical, it's a fall. Imagine you have a fall, you slipped or something, or near fall, and you don't think much of it. And then the next day you suddenly have this acute pain. Acute pain is not good. It has to be studied, okay? So let's focus on two of the things that we might think that it's easy to identify, but curious enough, it wasn't that simple. So we're going to dive into now is brainstorming together. How can I try to identify throughout my day what makes it worse and what makes it better? Okay, will be our focus. We thought it was going to be relatively easy because pain is something that is very intense in terms of the person can't really forget about it. But no, you can see by these results that
maybe random. And it could be some of the medication related effects if you're not aware of the influence of medication on dystonia.
So just trying to identify that sometimes it might not be so easy. But let's us give you now an example, again, based on your input. We'll give you several examples, and then we will connect it to Parkinson as well.
I got one example here after we do those that fits right into this.
Oh, yes. So bending over, lifting, twisting to the side. If we think about those compressions of flexion, typical posture are in Parkinson's disease, right? So bending over, what can we do about this bending over? Maybe for each one of these, I'm going to try to say the most important thing, but I want to highlight that any suggestion that I give has to be put into context. So I don't know exactly what you're going through, and you saw the amount of questions I'd have to ask you. But if I had to think about bending over, typically in Parkinson, the knees tend to be very rigid, which means that people don't actually flex them or unblock them often. The quadricep muscle, which is our main muscle here in our legs that help us sit and stand, is, I wouldn't say lazy, it is usually not so used or activated. We run away from it. So if I had to say something, is just try to see how bending your knees is happening, how easy it is for you to be able to bend your knees. And this is where sometimes we give a lot of emphasis to rhythm, like dancing has such good effects on walking and stuff because of this, because it helps you extend and flex your knees. Okay, keeping it, I will come back to this because we will be talking about it. But so this person shared with us about extended walking. So how about those vigorous exercise lovers who like to go and do 2 hours of walking. And then they start, I don't even, 2 hours, I'm already exaggerating, but it's true. There are people that do that. Even 1 hour of straight walking without breaks can provoke pain. So if this is happening, I usually recommend people stop before they have pain. So try to identify the moment where you start feeling some discomfort. Literally stop for 30 seconds and then restart again. It's because, that will break down the cardio. No, it will help you not get back pain so you can actually do more, right? We want the quality of the movement in this. And then if we are walking too much and provoking back pain, then the consequences of that is that I'll stop exercising because I'll have a back pain crisis, right? So it's worth thinking about small strategies that could change the things that we do. Standing for long periods, about this one. So I usually say humans were made for moving, not for standing. So if you can avoid this, that would be brilliant. There is no benefit in us standing for long periods. Sometimes we might be in line at the shop or someplace, right? So my tip for this one, I would say, keeping your feet wide apart, like the police do, right? When they assessing, the trick that they use is opening wide their feet, and that helps them with their back pain. So hopefully that's a tip.
Yeah, someone's talking about cooking being a really good example for standing.
Yes.
Maybe put some cushioning or padding down to keep you a little bit less. Yeah.
There are some traditional things that we say for cooking. When I say traditional, it's like people that don't have Parkinson and have back pain, and then we'll say put a little stool and put one foot on top of it. That means it relaxes your back a little bit more. The problem with this tip for people with Parkinson, it might put you in an unbalanced situation. So just be cautious about these tricks.
What about somewhere where you could just sit, a little stool where you could sit down while something's boiling or something like that, so you're not
Well, I think anyone that cooks will say, but I always have to get up and go get something. So we have to be realistic about the strategies that we say. But yes, obviously, if you're dealing with back pain, you will be sitting anyway. I know people don't just endure it. So here's another example, which is weightlifting, certain yoga postures, and overdoing yard work.
Or snow shoveling right now, right?
Yeah.
That's the one.
So remember how I said things that make it worse are usually for a guide for solutions, right? And also things that make it better. So weightlifting, there's certain positions. Again, I will highlight the way that the muscles might be more rigid in certain points of Parkinson. Specifically the knees, the ankles as well. That means that even if you think you're doing a brilliant exercise, you will probably be compensating. And this is very important for the people that you're working with, health professionals, to also know. I have some resistance regarding weightlifting. I try to understand what's it for, but I will respect who likes it. But I'll probably do it against a wall or something. I'd have to find some way to identify the compensations. This could be, reach out to me if you're doing this and we can brainstorm. Yoga postures, I would probably comment that I don't believe in all the years of working with Parkinson that any exercise position should cause you pain. It makes no sense to me. Pain is a way for our body to tell us that something is not well. It guides us. So either we work in order to get to that position, so that means we might be doing half of that position and then increasing slowly. But working with pain does not make sense according to why it exists. I'm sure you can have lots of professionals then arguing the opposite, that work through the pain. I honestly don't believe that in all my years of working with Parkinson. Overdoing yard work. Well, people are enthusiastic in their activities. They love it. And so they might, yard work is usually bending down. And then when they get up, that's when the pain probably endures more.
Gardening, big one for sure on the knees and your back.
It's hard to tell people to stop doing things they love, right? It comes always down to good sense and saying, if it's really important for you to not have pain, just consider alternating positions or, just changing position more frequently. Okay, so just guiding through. So sitting too long, How many of us here sit too long? Everyone, right? Because nowadays we spend too much time on.
Computer all day, yeah.
But yes, and then sitting too long in soft chairs. Sometimes then the compensations, if I fall asleep, maybe I'll probably be more going to one side or the other. So this could obviously be an issue. I do have a gentleman that I suggested something that I thought no one would ever accept that suggestion. I said, do you believe that you would be able to get up maybe 30 minutes and just walk to the kitchen and come back? And so I asked him to try that. And he actually is a good student, which is very rare in Portugal. People don't like to exercise at all. And so I was fascinated that he actually tried it because he felt the discomfort and it worked. He said, I've been having less back pain.
So it's every twice an hour, every 30 minutes.
Yeah, so he would watch a lot of Netflix in the afternoon. And so what he did was just go into the kitchen more often. I even played with him. I said, why don't you go turn to your wife and ask if she wants something and you go get for her. Yeah. So yes, be creative in finding solutions not to have that. Remember, we were made for movement. So anything that's sitting too much or standing or walking too much or just exaggerating is negative. Here we come into the leaning forward. So as we were discussing about the cooking and washing dishes, we was discussing this with the person with Parkinson, atypical, or we were trying to make a list of all the things that people shouldn't do in the home so that they could give it to their care partners. And this one came washing dishes, sweeping, let's take out cooking. They enjoyed this exercise. It was, but it's true. It's a part of life, and probably we have to do it. We just probably shouldn't, or try not to do it too long, right? So even if I'm vacuuming, is it possible for me to do shorter periods? So I think this is, again, it's good sense, but sometimes we don't think about it because we just want to get it done.
And I feel like you should just get a Roomba and a dishwasher and forget about it. It's my technology.
And hopefully not step on it. So you see, I always have a negative side too. Okay, so someone says sleeping on my side, which brings us to sleeping positions, which is very interesting. It's very difficult for us to change someone's sleeping comfortable position. But it's true. It's when people wake up. I've had situations where as the person's getting out of bed, it's like a knife gets stabbed in my back. This is the description that he would give to the pain, right? So imagine throughout the night, the rigidity is coming in, right? Because the medication is less, the movement is less. And so I think it will be perfectly natural that the person might feel more stiffness. And as you're doing more abrupt movement without warming up, I would say, then the pain can be triggered. And the problem with this, it might stay with you for a while until you get moving and then it gets better. Some recommendations that I've told people is to, for example, to actually try to move their legs before they get out of bed so that they make this movement less aggressive. The truth is, the gentleman turned to me and said, but I need to go to the toilet quickly. And there goes my stretchly. So if you don't have that urgency, I think that it tends to work with other people that didn't answer that.
But and that gets into, someone was just asking about this, is sleeping on my side, maybe the sleeping position is a fault. Since back pain is greater in the morning, maybe the sleeping position is at fault. And I'd say there's a possibility for that, and you could set up, but it also could be the meds wearing off overnight. You could be waking up with less in your system.
I would probably say it's everything together, because the person is moving less during the night, so we're changing position less times as we get older, and obviously with Parkinson more. And so the rigidity will be more, yes.
And it's the same person wrote before this. If it's worse in the morning, wincing pain to bend down, for example, but gets better with stretching and movement, it must be just tight muscles, right? And it's like,
so let's try to define what tight muscles means. Tight muscles is linked to rigidity. Would you agree?
Rigidity being one of the 4 big symptoms in Parkinson's, the tightness.
So we obviously, it responds to stretching, but the best way to reduce rigidity, besides the medication being very effective, is obviously movement. Okay, so the stretching, you feel good with it, but the movement, which is the amplitude movement that we will come into, I'll give you some examples after, but it's just as people start walking and start moving, they will alleviate the rigidity. So sometimes we might use different words to describe the symptoms. Okay, does it make sense? Okay, so let's think about something that maybe research hasn't. I know everyone identifies weather, like with back pain. It's like I know the weather's going to change because my pain is come back. Well, it's usually the knees. It's more the knees, right? Of the most common complaints of musculoskeletal pain in Parkinson is lower limbs and back pain as well. So yes, we can't do anything about the weather. Unfortunately, we should be doing something about the weather, but that will be a tougher topic. Then we have stress. So the impact of stress or the lack of exercise. Okay, we'll touch upon these. Inactivity. These are all that seem very obvious, like driving for long distances. And that's where the inactivity sometimes in stressful situations, right? I would imagine that when we're driving and according to the traffic, we will become more anxious. Anxiety increases rigidity. Immobility increases rigidity. So it's a snowball there effect.
Yeah, and that gets into what the other question was doing. What about anxiety and pain? And yes, obviously,
yes.
Both anxiety and depression can have an influence on it, and maybe
it's one of the factors that can.
Yeah, absolutely. It may be treated by addressing the anxiety rather than the pain specifically, or both.
Mm-hmm. Okay, so I want to dive quickly into I think everything that was already referred will be showing up on what we already know about the changes that might happen in Parkinson. And so things that we mentioned and that are identified that can be contributing to back pain, specifically in Parkinson. Obviously, is the mobility that everyone talked about, inactivity. So just increasing the number of hours that we are not sitting should be one of the solutions. And then we have, this is an example of this person with Parkinson that I treat, and he's adorable. When I get there, he's always sitting in very uncomfortable position. He seems very comfortable, looks like an angel sleeping. But the truth is, once he wakes up, he doesn't feel his leg, or his leg is numb. It takes us longer to be able to start doing exercise. So it just mean if you are not, this happens naturally on daily basis. What I usually suggest is for the care partners or the families, negotiate taking a picture so that you can identify this problem. Because then you might consider, okay, so when I'm going to sit and watch a film, I know I'm going to fall asleep. So I'm probably going to exaggerating and sit, turn to in this case, this gentleman to the right. You see, so he knows that he's going to fall to the left. So what I always suggest to him, please sit on your right hip, because I know you're going to fall to the right if you do that. So there's tips and strategies that we can help, to be able to reduce this problem, or change a chair or do something with the chair. Just don't give up, okay? Because this is, and then we have obviously the other one that I said about sudden pain that might occur, and sometimes it might take, which is regarding falls or near falls, or having brusque movements. One of the most important ones is, why do I have back pain with Parkinson? I think it's very difficult to say that people won't have, because the changes in posture and in gait are part of the diagnosis. So we know that there's a lot of asymmetry. You can see by all these pictures here. If there is one side that is more affected, it is being, as I say, erased from the brain, right? So it's like your comfort zone becomes the side that's not affected. This is what's happening in the image here in the middle. And what you can see is the gentleman, his most affected side is the left. And when he stops to talk to this gentleman, all his weight is on his right. So if you imagine this is happening throughout the whole day, the changes that are happening in the back, it's almost impossible for him not to have back pain, right? That doesn't mean he will have, okay? Because I know, because the complexity of this is so interesting that it's almost like the body rearranges itself, but it compensates more. And on the walking, obviously, it's very specific to you, how you might not maybe be swinging your arms. This is a cue for anyone that obviously is recently diagnosed. Moving our arms is probably one of the causes of most of back pain, because it increases the rigidity in the back. So being able to focus on arm swings is almost like a mobility movement, right? An exercise when you're walking. It will help you also get a little bit more speed, so that maybe even your stepping will be better. These are tips and strategies that have to be studied specifically to you. Let me give you another example. So this is a gentleman that I follow for maybe 15 years. I see him twice a week, ongoing. I have been with him throughout these years, and so I cruelly take pictures of him all the time, and he allows me to share this with you. And just as he was holding on to his grandkid, and I was, okay, I want to highlight how you are compensating to be able to do this. Does it make sense for us to do this? He did have an episode of back pain where he did undergo surgery, but now he's much better. He's reacting to the surgery and to also the medication, and so it was that type of pain that is both musculoskeletal, and it was also related now with the wearing off of Parkinson. But as you can see, one way for us to be able to convince people that maybe you should rethink about, he's using his watch or some, and so my recommendation when I took this picture is like, how about when we're sitting down, when you want to sit down every time you want to use your watch, and he says, oh, then I have to get up. Yes, well, you train your muscles as well. So we have lots of friendship together, so we can negotiate these things. It's like, then you'll sit and stand, and that's good. That's also good. Now, a more difficult topic is knowing that unfortunately there are complications that happen in back pain, in Parkinson, related to the back, which I could not avoid to put. But the intention is just to give you knowledge that if you are dealing with this, that it's a situation that has been identified as something that's typically rare, which is dystonia. Okay, so it's a contraction from the brain. It's more than just rigidity, right? And it's a complex topic that could be a talk on its own. But I just want to highlight that it can exist. So there's something that we know, like typical Parkinson posture. There's a fight against gravity throughout the whole process, which means that your muscles will be used in different ways. And that's why you exercise, so that you can fight against that, right? And so that means the shoulders might be a little rotated forward, the head might be forward, the hips might be bent. Again, here we have the knees bent, but that doesn't mean that they are flexible, right? They might be rigid the same and blocked, as I was mentioning before. Okay, so this is something that we fight against. And if you are 99 years old, you will probably have this posture as well, right? So this is something which is kind of different from the image from your right, which is something that's more straight back, right? Bend forward. And these situations have a diagnosis on their own. If it does happen in this way, I just want you to understand that it's in a context of specific diagnosis, which, for the sake of time, we won't go into depth, but I did want to highlight that they exist. Okay, if you are dealing with this and you would like some further information, please do reach out to us. Send us an email, and I'm happy to share.
Yeah, but this is specifically due to a dystonia. This is not normal Parkinson's related rigidity, it just happens to be there. No, it's actually affecting their posture.
Yeah. And the way that people can distinguish this from, arthritis or something that changes in the back is this. So if we do have a situation like that, the person lies down, and you can see that there's no changes in the bones itself, right? So he recovers his position as he's lying down. This is how we distinguish differences. But I know it can be a very scary image.
It's not that common, but it's there.
It's true. It's rare complications. When it happens, it's possible to do something. So please don't give up if you are dealing with it.
No.
I have at least 3 or 4 people that I'm working with, and yes, it's tough, but we do have some benefit, and we try to help as much as we can.
Be sure to find an expert, though. If you don't have someone who knows Parkinson's, they're not going to know what's going on here.
Okay, so let's us continue focusing on solutions. Everyone doing okay? Yes? Okay, let me see the time, see if I'm misbehaving. Okay, so let's see what people suggested through the questionnaires about getting relief. So things that make it better, which is lying down or, just simply sitting as well. Now, the problem with this solution is that this has, again, an impact on how much I can do if I always have to be sitting down or lying down. So I can understand, but it is obviously a solution that is used. Then we had stretching exercises that people refer to, yoga, shoulder pushes. So sometimes doing other types of exercises, walking in small bursts, which is reasonable, moving around, exercise, doing activities, and then someone said oddly walking. So it's true. Sometimes the rigidity is, or the wearing off, or the person is feeling more rigid at specific times, and then the one way to distract themselves is to walk, and they actually improve. So I do see this often. So it's not odd. And then typical things that you might recognize. So taking medication for pain, right? Taking Parkinson medications, physiotherapy, massage therapy, and so on. As you can see, heat and hot is there.
So someone else here, this is a COX-2 inhibitor called Celebrex, which is another kind of a non-steroidal anti-inflammatory. It's a little easier on the stomach because it doesn't work on the same enzyme. COX-1 is usually what they work on. I will say for anybody dealing with, I'm the speech guy, right? But there's also a lot of swallowing. When you're taking these things, you want to make sure you're getting enough food in your stomach because they can be a little bit hard and maybe influence gastroesophageal reflux or GERD. And if you're dealing with a little bit, make your doctor knows about it. That's why Celebrex is a really good choice. Vioxx used to be around too, but Celebrex is around still.
So this is to show you, like, if you're wondering what do people do to be able to live with back pain, this is what people are trying out. There's one more here, which is I found very curious, which is in terms of the psychological impact of pain. So try not to stress too much. So we know that will increase it for sure. Engaging activities that will probably, I would say, distract you. So it's what I call rescue strategies. Try to see something that you can do that distracts you from your pain. I had this woman that it was praying. I had this other gentleman that's listening to music. So there has to, if you can find that, you can use it as a rescue strategy. Avoiding sitting, of course. We've talked about resting when necessary. Yes, okay, listen to music. Doing something else different in a different position, of course, yes. So it's like I'm exercising and I have back pain, and then maybe I can choose a different type of exercise. Trying to ignore it. Again, no therapist would eventually tell you the strategy. So it's nice to get this input from the group. And I think the last one is where I say, yes, there's actually evidence to suggest that people that swear actually endure pain better. The research to say groups that military actually a group of in the cold water versus someone that did not swear, a group that didn't swear, and they actually endured more. So
it's voice exercise too, I guess. Yeah, okay. Use your loud voice.
Okay, so thinking quickly on what type of exercises and treatments that can help. Here is an example of things that you already know, which is most rehab specialists and doctors will be talking about programs like the Lee Silman Big program, which is basically amplitude, speed, and an increase in the complexity. Okay, so different types of options. What's important about this is, like, if I'm dealing with back pain, let's imagine these people dealing with back pain and if the exercise that you are seeing makes sense. So supporting your hands on something, even if it's 2 chairs, and doing the exercises will help you endure the exercise better. Remember about what I said, working in pain doesn't really make a lot of sense, right? Because then your muscles are just going to get more rigid. So it's one thing if I work out a bit and then the pain is relieving, but if I'm working out and the pain is increasing, that doesn't make any sense. So just be critical.
Yeah, sure.
So using things like a TRX, right? That is enough for helping the person to be able to do different type of amplitude exercises. Maybe if the person is really dealing with severe back pain, let's try to get some alleviate a little bit of the rigidity in the trunk by doing something on the floor. The person is really more active, so I might use something more dynamic. Depending on the physical capacity, you can choose, as you can see. What I will highlight here is they're all amplitude-based movements. I'm sure you've seen lots of this. What I'm using is a lot of cueing. So in this gentleman, in this last one, it's like I want him to really touch the punching
bags, yeah.
So that I'm sure that I get the right amplitude going. Because just doing it on your own sometimes doesn't really get us the right movement. Or using a ball as a reference, right? So I'll just, for the sake of time, push forward. But these are all just examples. What does the research tell us about this? Typical back pain exercise recommendations is always obviously the yoga, the Pilates kind of situation. And when I look at these research studies, and it's impressive how everything improves, right? So you have 24 sessions, 60 minutes, 12 weeks. In 12 weeks, you got such incredible results. And the problem with exercise at this moment is that we can't have programs that finish in 4 weeks, right? Because it's what we know, the best research is that ongoing exercise is required so that you stay well. But the research says 4 weeks of doing this and you'll be better in terms of your perception of pain. Where I find the best results and also the evidence to support this is definitely with hydrotherapy, which is unfortunately gives us so much work to get dressed and undressed, to actually access a place that has something. It makes it challenging for people to have access, right? But it is where people have more results. And what there's lots of reasons for this, but the mobility, the movement, even if it's individual, as you can see here on the right, it's a very specific treatment inside water that improves back strength, muscles. But just moving inside water, it's just like those amplitude movements. It's like you move without pain. So that means you move more and you break the cycle of the pain. And if the water is supposed to be nice and warm, it will also relax your muscles. So by getting out of the pool, you already feel better. It is a recommendation. I know it's not easy for everyone, but this one was actually based on a research study that was done focusing on relaxing movements. It's basically Tai Chi inside water. It's called Tai Chi. And it was subjective to research twice a week, 10 weeks, 45 minutes, and the perception of pain improved. I do believe by my experience, it's just going inside water and walking inside water will already have an influence on the pain. But this is just to say that it is being targeted as a research in the research. Things that people often do that might be more helpful. So if I am dealing with some sort of back pain, maybe I can support myself with pole walking without creating too many rules about it being in the back. You know how they probably teach you to have the poles facing backwards, bring them more forward, use them as a support, keep the aerobics going. And so it's a better use of the poles without creating too much emphasis about the coordination. Because it will help you correct a little bit more of the posture, and it will help you endure longer walks. And it also has been shown to improve back pain as well. If you're thinking about what would be specific, this is just examples of ways that you might see in the clinics of people trying to find a position where the person can work in the most upright position. So on your right is actually someone that is dealing with capricornia. So it's those severe situations that I was telling you about the person. But it is possible for us to do the exercise. And again, finding positions that do not provoke pain. I'm going to push forward on this. It's just examples of research studies and jump on this. It's an example because it's the most recent thing that has been highlighted to reduce, to improve posture and potentially back pain, which is actually climbing. Now, this can be highly scary, as you can imagine, because climbing it requires a lot of effort, and it's probably not for everyone. But if you do feel like trying it out, you have a program very close to you if you are in Washington, D.C., in Virginia.
So someone was just asking about the climbing, and upending Parkinson's, it now moved naturally, and it actually enjoys a couple of studies that they're working on, or one that's going on now and one the little one before. And a good friend of ours, Walter Metzler, put out a great study a couple of years ago that you're drawing for.
And so in the clinic, when I have someone, as you just saw before, what I do is usually use, now I can't find the word in English, with those bars that you...
So that monkey bar kind of thing, or?
Made of wood.
Yeah, like slats.
Okay, sorry, I can't the word. But basically I improvise. So it's not about the person going all the way up for me. It's about working in this position. Yeah. So most typical back pain programs is about people who were working on the floor, as you saw in Pilates, right? So all fours. And I think working in this position is actually quite brilliant, because just vertical walking, right? Just being in this position and doing exercises in this position without going truly up or down is very, as you can imagine, all the muscles, whole body workout that you have there. So it's quite interesting to explore, not necessarily in the context of time. There are tips and tricks that if you have access to a physiotherapist that's been working with Parkinson, they will have all sorts of strategies that they learn from the patients, that they learn from themselves, from trying things out. And so it's just, please do not give up on trying to find a solution for your back pain. This one, for example, for standing a long time, it's just if because of all the changes and the feet are more together, there's changes in posture, having the notion where I am in space. So just basically leaning against something is enough to help the person endure longer standing positions. So that means you are just giving a tactile information to your brain to where you are in space. And so you reduce its stress of trying to contract all the muscles to realize where they are, right? So there are very simple tricks that you can learn from this therapist. And I'm going to use a practical example here as well. There's someone that said, I love to run, but every time I try to pick up running again, my sciatica flares up. Will I ever be able to run without pain? I think no one has the right to take hope away. And so what I would say is like, if we look into the situation, is there moments, is it possible for us to assess how the person is running? Because sometimes the person might be running and compensating too much. Maybe one foot is dragging more than the other. Maybe one arm is not moving as the other. And so that could be bringing on strain on the back. So what if we start trying to run for short periods of time on the treadmill with the handrails, so holding on to it, and then just gaining that capacity? So I would say no one should be taking that hope away. It's just how you train that, and obviously trying to figure out if there's any specific changes in the back that are more severe, that have a different type of intervention. But there's no reason why people shouldn't be running again. And if I had to leave one tip, would be this: when you're walking, when you're running, when you're standing, there is like 99% of the people with Parkinson have their feet very close together. Either it's their heels that are most closely, or the feet in general. And so that means any movement that you're doing, if you are able to keep the space between your legs, it will help you endure better the posture and the position and lower back pain.
You're the first person I've ever heard say that, and now I can't unsee it. You showed it to me at a conference we were at like 7 years ago, and I'm like, oh my gosh, it's bringing them in there. It's a compensatory thing, and if you can fix that, that's a huge thing.
Now, I want to leave here, and there are different forms of Parkinson. So a typical Parkinsonism, this might not be like this. So they might have their feet too wide apart, and there I'm usually telling them to put it together. So it's just it's important to just identify where you are and what works. Okay, so I'm going to finish quickly, but just by organizing what we are talking about. We hope that by helping you recognize if it's related or not to Parkinson, it will help you also identify better, what's causing the pain, maybe using a tool so that you can discuss it better with your neurologist. And then maybe you can see if optimizing the medication is possible at certain times, so that you can maybe make dinner, right? Someone had said, I was having back pain at the end of the day, and then I changed my medication. Now I can cook dinner again, right? So this has a real impact on people's lives. And then exploring these non-pharmacological interventions. Obviously, there's so much that people can try. If you take advantage of these educational programs, I think you can at least try to avoid things that did not work with others. And now before we go, I just, there were several questions. Is there a specific one there?
I'm just, as someone was asking about walking on a mountain trail, hiking on a mountain trail, and that's something. Someone talked about.
It caused pain?
No, they want to know if it's a good idea, and it's like, well, maybe trail running is not your best one. I'm just trying to get some clarity.
It would always be like, do you have experience in doing it? Do you really enjoy it? And then how can we explore it so that you do it without any risk?
Falls are the enemy. You want to avoid that.
Yeah.
You want to make sure that you're not at risk.
Okay, so here is just bear with us. We have a few questions that people placed that we wanted to get to. And this was actually a very interesting question, which is, what if my back pain is stopping me from doing exercise? And someone actually commented, the very exercises that I have to do to fight against the progression of the disease is the ones that I can't do because of my back pain. And that might induce fear. And what we know from research, the type of exercise that best helps you fight against the progression of disease is aerobic exercise for now. That's the best evidence, which means like if you having back pain and you are not able to do those Lee-Solomon big and amplitude movements, you can do it in sitting position. You can do it on a bicycle. You can get that aerobic exercise from another type of modality. So I hope that doesn't stop you from exercising and thinking that's the only thing that exists. It's the concept of aerobic exercise, which can come in different ways, right? It can be Nordic walking, it can be swimming, it can be walking. As long as we get that amplitude in those type of exercises, that's rich. So this was just someone that was in a boxing class, and he was dealing with back pain, and so we had a strategy whenever he felt it's not giving, he would flex. Oh, what a pity. He would just bend down to the floor and come up and do it 3 or 4 times. So he found a rescue strategy to be able to continue in the class. And so as long as it's negotiated between us, that's fine. Okay, how do I walk with back pain? Okay, so again, trying to understand why you're getting back pain when you're walking. So understanding what are the changes, what are the compensations that may be provoking that. And then things that you saw here as an example, maybe the Nordic walking can help. Maybe where you do it, maybe opening more your feet. Again, it's very hard for us to give a very specific answer to this. Depends on the person, depends on your location, what you do throughout the day. And then reinforcing exercise or physical therapy. If you want to identify these things that I'm saying, like how exactly am I walking? How exactly am I performing this exercise? Why is this provoking pain? You might need the support of a professional to be able to help you get that information, and then obviously build your exercise so that you can work on it. So I think both obviously are important, one specifically to guide you.
Someone's asking about what do you mean with amplitude in exercise?
Okay, so if you amplitude, if you can see my hands, is basically when the doctor asks you, I'm going to give you an example here that's possible on screen. It's how big, the bigness of the movement. And what we know is when the doctor asks you to do this, there's a tendency for it to become small. So what we know in Parkinson is that the movements become small and the amplitude, the bigness of the movement is lost. And so that's why everyone is always recommending, let's do the Lee-Solomon big program, which is the one that's most well known. But as I said, it doesn't have to be specifically that, but it has to be a group of movements that bring you up, that open you up. Because if Parkinson is making you smaller, you want to become bigger. And then once we have the amplitude, we also have to do it faster. We have to be able to do this faster as well without it breaking down. And that's why it's like, get the amplitude, get the speed. And then when we are doing this and we are distracted with something else, we tend to go slow. So this is where cognition and distractions in life make us also go slower. So there's certain ingredients that we want in the exercises so it can help you better.
If you keep talking about LSVT big, I think we also have to say PWR, Parkinson's.
I'm just saying that one because usually it's what the doctors, neurologists usually recommend because it's what's on their guidelines. But it's a program that was studied.
Yeah.
4 weeks, the high intensity, but it's the amplitude that is in those that showed the benefits in those programs.
And interestingly, that's that pain study I was reciting before. Abersbach was the one who did the LSVT big. So it does have more research, but we met at PWR like 15 years ago.
So you saw the examples of all the exercises that I showed in the videos, and I'm sorry we didn't go into depth into them, and I'm happy to send the videos to you and explain what we are doing. But it's just, yes, exercise reduces back pain, mobility, amplitude, rotation, depending on the cause, it will improve the stiffness. Okay. What more can I do to reduce the pain and be more active? I hope by the end of this talk that we have answered this question about maybe what type of exercises to address. And this was also a very interesting one, which is why our movement specialists are unwilling to address back pain. I think that what came to mind when I saw this question was really what we started off with today. You can see how complex pain can be. You can see how the conversation would take up a whole consultation. We do know little, but we know much more than we knew 10 years ago. What we lacking now is what would work best. So what type of exercise would work best? With research, based by research. And I think because of the uncertainties, I think it would be normal that they wouldn't address it at this moment. But pain related to Parkinson is something that is highly studied and talked about in Parkinson congresses. So it will shock me if they're not aware of its existence.
Pain in general, for sure. Yep.
And yes, I think we can finish here. Thank you, everyone. Wishing you no bad way.
Yeah.
I hope you get control of it.
Yeah. Don't stop looking for it because you can find a way through it. All right. Have a good one.